everybody will grab and chat with you, because you are the #1 enemy of the state right now with all your big wins.
My #1?
Maybe #2, #3, I don't know. But
I was hoping
in the top 10.
I thought hoping Ingram was going to have her bookend between me and Jay by the time both of our testimonies will overturn the.
So funny.
Really?
You're
So you guys
definitely
testify in order to do that?
definitely in the top 10 most wanted. You're in good company.
Oh, yeah, you're in good company.
We feel you.
All right. Okay, here, guys. Hello. All right. So I am here with Dr. Peter McCullough. Hi, Doctor. Thank you so much for coming.
It's great to be here in the teaching lab.
Yeah.
This is, we're going to get right back to the mother of learning, and that's repetition. So we're going to repeat a lot today as we go over some of the complications that we're seeing with the COVID-19 vaccine.
All right.
Okay. So I guess one of the questions I have for you is maybe you can go over the anatomy, at least like what is getting injured with the vaccine. I've heard a lot about myocarditis, pericarditis, but what is that?
Well, let's just start from the very beginning. The vaccination is given in the deltoid muscle, which is here. It is a injection that is lipid nanoparticles, whether it's messenger RNA or adenoviral DNA. Those lipid nanoparticles are rapidly taken up into the venous circulation, and they are returned through the venous circulation to the heart, to the right side of the heart. We know from a paper by Ogata and colleagues that within an hour of vaccination, that there is actually measurable spike protein in the human body. So this is rapid. I can tell you these lipid nanoparticles are like a rocket in the human body as they distribute. Now, as they move through the right heart and then are pumped out to the systemic circulation, each person is different, but there must be a mosaic of cells that is touched by the lipid nanoparticles as they begin to distribute in the body. We know from a biodistribution study performed by Pfizer for the Japanese in animals, not using the messenger RNA, but just the lipid nanoparticle vehicle, that we learned that they hyperconcentrate in the human ovaries. And in this example here,
She actually had a complete hysterectomy because of the vaccine.
so in this example here, the ovaries would be down in this part, in the pelvis. This anatomical specimen has had a hysterectomy. So we know that the ovaries would receive distribution. If we look back here, and we have to go to the retroperitoneum, just on top of the kidneys are the adrenal glands. So the adrenal glands do get seeded by the lipid nanoparticles. And then very importantly, we believe the heart is seeded probably through the arterial phase of circulation, and the heart receives its perfusion through the coronary arteries. The left main, the left anterior descending, left circumflex, and the right coronary artery. Then there is a seeding of the heart with the lipid nanoparticles, and they go elsewhere. We do know that they go into the brain. There are now high-quality autopsy studies showing where the nascent spike protein is produced in the human body, and in fact, it occurs in the brain. But let's focus on the heart. I'm a cardiologist by training here in Dallas, Texas. I just finished in the hospital seeing patients with heart problems, in fact, complications after COVID-19 vaccination. The one that's most concerning, that the FDA agrees, and all the regulatory authorities agree, is actually directly caused by the vaccine, is myopericarditis. So this is the heart muscle here. This is the right ventricle that overlies the left ventricle. The right ventricle is anatomically more anterior. The left ventricle is the greater mass of the heart, and that lies in back here. That's what makes the heart heavy. And if we take a heart specimen out of the chest like this, it's covered in a white sac called the pericardium. The pericardium has an external sac called the parietal pericardium, and then the sac that's actually physically attached to the muscle of the heart. That's the visceral pericardium. When the blood is actually perfused into the heart, and there is the local production of spike protein, in a paper by Avolio and colleagues, they demonstrated in a preclinical model that the spike protein is actually expressed in pericytes. These are support cells that are around the blood vessels and around the myofibril bundles, the bundles of contractile proteins in the heart, and that these pericytes then express the spike protein, and there is inflammation. Actually, the body immediately responds to this. The human heart should not have Wuhan spike protein in it. And in fact, immediately there's an attack. And the immune attack then starts to cause cellular destruction. There is invariably destruction of cardiomyocytes, the precious heart muscle cells that we rely on for the contraction of the heart. And there is a release of cardiac troponin. Cardiac troponin is the blood test that we use to evaluate for a heart attack. And indeed, it is elevated in patients with vaccine-induced myocarditis 10 to 100-fold higher than what we would see with a heart attack, let's say, in a man my age, and far higher than we'd ever see with troponin elevated with COVID-19, the respiratory illness, in the hospital. Almost everybody sick enough to be in the ICU can have an elevation in cardiac troponin, whether it be due to COVID, pneumococcal sepsis, staphylococcal sepsis, etc. That's not myocarditis. The myocarditis that we're seeing with the vaccines is a distinct syndrome where the heart itself is under immediate attack and injury from the COVID-19 vaccines that induce the production of the spike protein. So we see troponin elevation, chest pain, signs and symptoms of heart failure, EKG changes, which is a considerable ST segment elevation globally over the heart, and then about a quarter of individuals, there's actually reduced left ventricular ejection fraction. So we do a cardiac ultrasound right here on the heart, and we actually measure in a variety of different windows, and we can see the pumping function of the heart is reduced. This is a very important concept. In about a quarter of individuals on the initial review by the US FDA in June. Now, when we go to the literature, people have asked me, Dr. McCullough, how long does this last? The syndrome lasts for about 3 to 6 months, and a principle of myocarditis is individuals may not have any physical exertion. This is very, very important. We cannot allow any physical exertion because in the setting of an inflamed heart, extreme physical exertion can be a trigger for sudden death. And we are seeing cases of sudden death on the playing field now by the scores. Now, we don't know if these young athletes who are professionals have been vaccinated, although most leagues, soccer leagues, rugby leagues, the NFL, NBA, the baseball players have been told either through policy or by direct mandates that they must take the vaccine. We infer many have. And indeed, if they are either not having symptoms or in a sense aren't recognizing subtle symptoms of myocarditis, that extreme exertion, it's clinically feasible that it could be triggering this wave of sudden deaths that we see. The most common cause of sudden death in an athlete is actually an abnormally thickened heart, interventricular septum, called hypertrophic cardiomyopathy. But with modern day electrocardiography and echocardiography, we screen out that condition. We never see athletes drop in large numbers on the playing field with sudden death, and yet there's been scores of them. The other principles of treatment is, besides rest, physical rest of the heart, those with signs and symptoms of heart failure, we prescribe drugs called ACE inhibitors or angiotensin receptor blockers, and then evidence-based beta blockers, busoprolol, carvedilol, and metoprolol, succinate, in order to prevent the development of heart failure. And then we manage the myopericarditis. If there are considerable pleural pericardial symptoms, such as chest discomfort, it's my clinical practice, I prescribe colchicine. There has been a large myocarditis trial sponsored by the National Institutes of Health years ago. Dallas played a huge role in it, actually. It's called the myocarditis treatment trial. And it showed that routine use of corticosteroids are not beneficial. And it showed routine use of biopsy wasn't beneficial. So we don't need to biopsy to make the diagnosis of vaccine-induced myocarditis. We need to basically arrive at the clinical diagnosis. We know that there's shot number 1, and then on shot number 2, and even now with Johnson & Johnson, there is a second shot a month later. It's shot number 2 that seems to be an explosive risk for the development of this myocarditis syndrome.
Yeah. I had personally a patient in my whistleblower video. I had a patient that had developed a cough on a Tuesday after his second dose, And it continued so much that on Saturday, he's now in the ER, and he also had COVID naturally the year before. So not only did he also have COVID, he got the second jab, and now he's got myocarditis, pericarditis, and congestive heart failure.
Oh boy.
Yeah.
So he's clearly in trouble. I've reviewed in multiple national audiences a paper that was published in the journal Circulation Research in 2019 before COVID.
Okay.
But it reviewed the question of what happens after myocarditis. What is the outcome of it? And I assume vaccine-induced myocarditis, which appears to be a fairly severe version of myocarditis, we can see it with parvoviruses, other adenovirus, sometimes idiopathic, that paper would be valid in terms of generalization. The answer is about 13% will be stuck with progressive worsening of left ventricular function, like the case you described. There is a proportion, let's say a quarter or so, that's going to be damaged but stay the same, and then other proportions that will improve. There is a portion of patients with myocarditis, thankfully, they don't have any obvious dysfunction of the heart. They simply have discomfort, and it's going to go away. But I can tell you this much, it's not mild, and it's not rare. And we know this now because a paper by Tracy Hogan colleagues, University of California, Davis, showed that among thousands of cases of myocarditis in the VAERS and VSafe databases, age 12 to 17, that 86% of these teenagers were hospitalized.
Wow. 86%.
It takes a lot to hospitalize you.
Yes,
If I was consulting on a teenager and they had some mild pleural pericardial symptoms, some mild chest discomfort, and my exam was okay, and the EKG and laboratories were okay, I'd send them home.
Right.
But I can tell you what's really prompting this are these sky-high troponins. I mean, 100-fold higher than we see in myocardial infarction.
Wow.
So this is not a heart attack. I've been in so many interviews that say, Dr. McCullough, are these young kids having a heart attack? No, they're not having a heart attack. A heart attack is actually an occlusion of one of the coronary vessels to the heart, which, buildup of cholesterol in the arteries to the heart. That's the common scenario. So here's the heart shown in a big picture here. This is the left main. This is the left anterior descending and left circumflex vessels. I had a patient today in my office. He's a gentleman who's 63, so he's about my age. He took the vaccines. He took shot 1, shot 2, and it was about a month or two later, massive anterior wall myocardial infarction. And so he presented with a sudden onset of chest pain, dramatic EKG changes. He was taken to Parkland Memorial Hospital here, underwent coronary angiography, and had a stent placed. And now we are trying to analyze his situation and say, is it in any way related to the vaccine? Now, in the setting of coronary atherosclerosis, what we know is what triggers the heart attack is thrombosis. So some surge in the body's own blood clotting system, because blood has flown past those configurations of partial blockages for probably years, if not decades. What caused that sudden explosion in the thrombosis and what's called the plaque rupture in the coronary arteries? And a recent abstract at the American Medical Association, American Heart Association, AHA abstract this year, evaluated patients who took shot number 1, shot number 2, had the baseline, and then looked at blood factors that are related to triggering of atherosclerotic plaque and causing a heart attack. And there was a multiple increase from before vaccination to after vaccination. The conclusion of the abstract was, in fact, COVID-19 vaccination could trigger a heart attack, just like it was just like the case that I saw today in the office. So I want the listeners to know that the cardiac risks in young people are myocarditis. We've recently showed in a paper by myself and Jessica Rose, published in Current Problems of Cardiology, that the myocarditis risk extends in men all the way up to age 50. And we know the relationship of myocarditis in terms of gender is about 80% men, 20% women. So the boys will always predominate over girls. And that was shown actually before COVID-19. It's clearly true, COVID-19. So there must be some relationship to androgen receptors and the surge of hormones that we see through puberty. By the way, the risk really surges after the boys go through puberty. It's not so much in the younger individuals. And then older individuals my age, the risk isn't myocarditis so much, it's actually now we understand triggering a myocardial infarction or triggering an ischemic stroke. In a myocardial infarction would actually involve the heart muscle itself here. The myocarditis, by the way, is a uniform pattern of inflammation around the heart. And in now the lethal cases described by the Washington University in St. Louis, described by in Korea in a paper by Lim and another one by Choi, they've described fatal or near fatal cases. We know the inflammation in the heart is massive. It can involve the atria, the ventricles, and the conduction system. In the fatal case reported by Choi and colleagues, it involved the conduction system. And this 22-year-old Korean man, who in him a COVID-19 wouldn't be a clinical threat, the respiratory syndrome, he in an ill-advised manner took the vaccine, and then it developed a chest pain. He had chest pain for many days. He went into the hospital and he died within 7 hours. So we're going to see many more cases of myocarditis and cardiac death as more and more young people undergo COVID-19 vaccination. We know in this group that there's no opportunity for clinical benefit because it's a very mild syndrome. We know in the paper by Walther and colleagues, age 5 to 11, and then by Frank and colleagues, age 12 to 17 with Pfizer. Now, age 5 to 11, Pfizer is 10 micrograms of messenger RNA, shot 1, and 3 weeks later, shot 2. And we know in 12 to 17 is 3 times the dose, 30 micrograms of messenger RNA, shot 1, and then shot 2. We know in both of those clinical trials, published in the New England Journal of Medicine, when we combine the data in about 4,500 individuals, that the vaccines basically prevented about 24 cases of the sniffles. That's all they did.
Right.
That's all they did. There was basically no clinical benefit in terms of reducing the risk of spread. There was no clinical benefit in terms of hospitalization or death because it didn't happen because it's such a mild syndrome. And so these kids who get, on average 4 colds a year, it's an imperceptible benefit. So that we would assume that in a sense, whether they took the vaccine or not, to that child's health, there's no difference because it's not really impacting them in any way.
And the thing that I find very interesting is, we knew that information very early on, March, April of last year, we knew that it didn't affect children. And we went through this entire year and a half not seeing large, cases of children dying. I think when I looked at it, and the last time I really looked at it was maybe September, and it was less than 1,000, right? From 0 to 17.
Children can get COVID-19. I've seen and examined these children. I've advised on it. They need little more than, when there's severe symptoms, some albuterol nebulization, budesonide nebulization, oral prednisolone, oral azithromycin, liquid format. And we can use even weight-based aspirin if we need. The biggest issue in children is probably fever control, and they get through it. So children do get COVID-19. It's typically very abbreviated. Remember, children have a thymus gland. They have a robust immunity. They're considered an immunologic buffer. Dr. Angelina Farinella here in Houston, Texas, who is a vaccine expert, and she has been very involved in vaccine development, clinical trials, clinical use, has basically told us there's no clinical rationale for a child to receive a vaccine because COVID-19 isn't a serious illness to them. Of the deaths that have been recorded, and there have been in the United States deaths recorded, we tend to have a relatively liberal attribution to COVID-19 because of the way the practice pattern is in testing. Because individuals come into the hospital, they're tested. If they're COVID positive, even if they come in for some other reason.
Right.
If a cystic fibrosis patient came in with a pseudomonas pneumonia and they were COVID positive and they died, it would be considered a COVID death. Right. We know that with deaths like this, that we have a situation, about 600 deaths annually. By the way, that happens with influenza. There's about 600 deaths per year in influenza. Last year we had relatively little influenza. Many of that was, in a sense, replaced by COVID-19. It's been a net difference. Other countries that more assiduously assign COVID-19 as a real diagnosis, such as Germany and Sweden, 0 cases. They've had 0 cases. The United States, it's about 600 deaths. Now, Dr. Marty Macri from Johns Hopkins, Dr. Scott Jensen of Minnesota have analyzed all the cases, and they both agree there's one child who they think was previously healthy who died of COVID-19. Sadly, the child received no treatment. So, we can treat COVID-19 in children. Scott Atlas, who was in the White House with the Trump administration, I recently had dinner with him, and he gave a presentation at a symposium held by Dr. Pam Popper. What he indicated is that school teachers for elementary and junior high are the safest professions, the lowest risk of COVID-19. We know that because all the kids are back at school. There's been no credible student-to-teacher transmission. We knew that last year in Dallas. We had the Dallas Independent School District shut down, but the parochial schools stayed open. No difference in transmission, right?
Right.
And then, very importantly, at the September and October pediatric meetings of the FDA, in the minutes, the general agreement by all the experts was that through May, 40% of the children had already had COVID-19. They've already had it, based on all the estimates that are available. Now the Delta outbreak has to be considered, that big spike we had in May, June, and July, August, tailing off. My current estimate is 80% of kids are through it. And you know that because now we're back at school, no outbreaks. And believe me, there's a lot of kids in elementary school and junior highs all over the country, no outbreaks. So it's over with. For the kids, it's over with. If the kids never took a vaccine, then there would be no chance of myocarditis, no chance of myopericarditis. There would be no chance of other untoward effects. So we could review that in children. We do know that there are cases of Guillain-Barré syndrome, and there is an FDA warning on Guillain-Barré syndrome for J&J. Now, the kids should not be receiving J&J, but the mechanisms are so sufficiently similar. Clinically, I could consider a child who takes Pfizer who develops Guillain-Barré syndrome as likely attributing the Guillain-Barré to the vaccine if it had the right temporal relationship. That is an ascending paralysis from the legs moving upwards, and it's pretty rapid. Once it starts, over the course of a day or two, the children will stop feeling their feet and their legs, and it'll progress up the body to the point where respiration is impaired. Many of the children with Guillain-Barré syndrome will actually have to go on the mechanical ventilator, get support. We do plasma exchange. We can give corticosteroids, try to resuscitate them. Many times they need a tracheostomy. I saw a patient today in the clinic who took one of the COVID-19 vaccines. I think it was either Pfizer or Moderna, and he had a partial Guillain-Barré syndrome where he lost some of the sensation in his right lower leg. And he had some characteristic features. He said that certain things he could actually make it become more prominent. So Guillain-Barré is a peripheral type of syndrome, but it ascends. We also know in children, very importantly, Bell's palsy. And the Bell's palsy was in the registrational trials. There was a few cases. Now there's been thousands of cases of Bell's palsy. That is a facial nerve paralysis where one side of the face begins to droop. Now it disfigures the face. The parents and the children absolutely are not going to like this. I mean, anything that impacts facial appearance is very, very important to the self-efficacy of a child. Could basically change the course of a child's life. That having Bell's palsy particularly is permanent, but the medical hazards are the eye cannot close correctly. And when the eye does not close correctly, it's constantly dry and irritated. So there is a corneal type of injury that happens, a risk for corneal ulceration, dryness. So we have to tape the eye shut in Bell's palsy every night and put ointment in the eye. And then the other thing is the mouth doesn't close correctly, and there is a drooling from the corner of the mouth, what's called a cheilitis. And the cheilitis then injures the mouth, and the child from that point forward is always managing a dryness, a air irritation to the conjunctiva and the cornea, as well as this cheilitis and the facial disfigurement. That's Bell's palsy, and I'm telling you right now, the thousands of cases that occur after the COVID-19 vaccine, some of them are going to be directly related. Now, the FDA does have warnings for people that would fall into this group, but particularly those going to college, for Johnson & Johnson, and it actually has to do with, we need the brain specimen back.
Yeah, right behind you.
Right behind me. Here we go. It has to do with a syndrome. The this is very important, Johnson & Johnson, and then outside the United States, AstraZeneca, and it has to do with thrombosis in the veins around the brain where the blood is moving slowly. Okay, so that is the cavernous venous thrombosis deep internally and the transverse sinus. The blood flows slowly there, and because the vaccines cause the body to produce the spike protein in large quantities, and the spike protein is now known to be circulatory probably for at least a month in some individuals, that is a long time to be exposed to this prothrombotic factor that will precipitate blood clots in slowly moving zones of blood in the brain. These thromboses can present with cranial nerve palsies, having double vision, weakness, headache, and then importantly, they're difficult to treat. Many times, they're not amenable to the use of thrombolysis or clot busting drugs. And then we have to use neurosurgical techniques to try to remove the thrombus and try to restore the cranial nerve function. Many are left with an amblyopia or diplopia. The eyes are no longer coordinated. It can be, if you use redirecting glasses, it's really a giant issue. I can tell you clinically what's going on with the vaccines is headache is common. People say they have headaches. They have ringing in the ears, tinnitus, hearing loss. And the hardest thing to know is it just the vaccine itself damaging the brain, or are we dealing with one of these thrombotic syndromes? And so invariably we're doing axial imaging. So we're doing CT or MRI imaging. That's adding new expense. These are people who took the vaccine because they wanted to do it to keep their employment, and now we're spending time with doctors' offices, neurology consultations, MRI, and CT. We're adding up unnecessary healthcare costs, and it's creating a tremendous amount of commotion. Now, in the journal Hypertension, it's already been described a syndrome where in those with hypertension, and they take the vaccine, they have a giant surge in blood pressure and can end up with intracranial subarachnoid hemorrhage, actually bursting the capillary and blood then filling up the calvarium and smushing the brain, and that actually requires a craniotomy and to remove the blood clot and lower the blood pressure. That's happened, and there was a wonderful lady in her 70s who was feeling perfectly well. She patriotically took the vaccine. On shot number 2, had this surge in blood pressure and suffered an intracranial hemorrhage. Her and her son desperately had to beg for care in a hospital on the East Coast and actually had a late evacuation of thrombosis. She appeared on a Laura Ingram angle on Fox News and told her story. Later on, both her and her daughter called me, and we went over the clinical description and reviewed that. I said, yes, that's exactly what's described in the journal Hypertension. Separately, there can be, and there are case vignettes now, of aortic dissection with this severe rise in blood pressure, and then as well as a carotid artery and vertebral artery dissection. So we're seeing vascular dissection syndromes, maybe in previously predisposed individuals who now are getting exposed to this pathogenic protein, the Wuhan spike protein, that is this spine on the ball of the virus that is known to be so dangerous to the human body.
Yeah, and it's different. Can you tell our viewers, so this, we talk about the spike protein going throughout the organs, right? How is that different from the vaccines that we've gotten in our muscle that just stays there?
You know, we never know if vaccines, in a sense, stay in the muscle, because we inject anything in the muscle, it's going to be taken up, right? So we give other intramuscular injections. We actually give them for a reason. We want to, if we were to give an antibiotic, let's say ceftriaxone, and we were to give it intramuscularly, we actually do want it circulating around. So things get in the deltoid muscle, they do circulate around. The vaccine that comes to mind that basically leads to a sore arm and we think no systemic effect would be the tetanus shot. Everyone here listening in the audience has had a tetanus shot. That's tetanus toxoid. It's a small amount of the toxin that's on the tetanus bacteria, as an example. But most of the other vaccines, people are used to these. They're either inactivated vaccines, such as pertussis or what have you, or various bacterial products, or inactivated viruses. So, for instance, we have the inactivated varicella zoster virus, which in a lower dose is the chickenpox vaccine, and in a much higher dose, it's actually the shingles vaccine. But it's a virus that we give to the body, but the virus itself can't replicate. But it's still alive, so our body can respond to it and form immunity. So anybody listening who's my age range, and you've had the shingles vaccine, you know what I'm talking about. There is, in a sense, a local inflammation there because the virus is still alive and we're responding to it. But the point is, in these other vaccines, these live attenuated or killed virus vaccines or protein-based vaccines. Another one's hepatitis B, that's a protein-based vaccine. They never invade human cells. Okay, they never, for instance, these proteins, we don't believe that they cross the blood-brain barrier. There'd be no reason to cross the blood-brain barrier. But when something's loaded on a lipid nanoparticle, it is going to go to lipophilic organs like the brain, like the adrenals, like the ovaries. And the great concern here is that the genetic payload is deposited into these organs. They begin to, the cells, some cells, in a sense, are harnessed to produce the spike protein, the 1200 amino acid protein on the surface of SARS-CoV-2, which we know is pathogenic. We know in high doses is lethal. In a sense, everybody is getting hopefully a sublethal run with the spike protein. It's a survival test. Sadly, with the number of deaths that we've seen after the COVID-19 in the US CDC VAERS system, we have about 18,000 deaths, which about half of those are domestic deaths. They occur mainly in our seniors, those who are in their 70s and 80s, and so that run of the spike protein, if you will, or that exposure to some is just simply not compatible with life, and that it is a lethal exposure to the spike protein. Analogous to getting lethal exposure to SARS-CoV-2 in the same pathophysiology. So in many ways, the COVID-19, the respiratory infection, and the COVID-19 vaccines are one and the same in terms of the exposure to the spike protein. The big difference is that with the vaccines, we believe the exposure to the spike protein is much greater. And how do we know that? Because with the respiratory infection, we actually can look at antibody rises. So the antibodies that arise in response to the respiratory infection are relatively modest against the spike protein. But with the vaccines, they are 5 to 10 times higher. The only way one can have a higher antibody rise to the spike protein is get way more spike protein. It's an antigen exposure. With the natural infection, there is a modest rise to the spike protein, but there's also antibodies to 27 different proteins. With the vaccine, there's just antibodies against one spike protein, the spike protein.
And even the booster shot that they're getting is still the same spike protein from 2019.
And so what we've learned, and what's really been, I think, probably the biggest shock to all of us, is work done by Bruce Patterson out of Northwestern and Stanford, and now a recent paper from Banzel demonstrating in the respiratory infection as well as the vaccine, this spike protein, once it circulates, is sprayed in the human body, and it takes months, if not over a year, to remove. The body has to clean this stuff out, and that's what Patterson showed. He found the S1 segment in the respiratory infection in CD16 positive monocytes up to 15 months after the respiratory infection, and now Banzel has reported in the vaccinated individuals, Patterson has as well, both the S1 and the S2 segment after vaccination in the human body for as long as we can see after getting the vaccine. It's an install of the spike protein that we must phagocytize out with our cleanup cells. And I asked Dr. Patterson on a recent issue of the McCullough report on America Out Loud Talk Radio, I said, is there any situation where this has happened before, where we have an infection and there's something from the infection in our bodies for that long? He goes, yes, there is. You know what it was?
What?
Lyme disease. He says people get Lyme disease. There are fragments of Borrelia burgdorferi in the body for months or years afterwards. And our body, no wonder people have post-Lyme disease.
Yeah.
No wonder people have long COVID syndrome, right? No wonder there is this residual neurologic, peripheral neuromuscular this brain fog, the types of syndromes we see in long hauls. There could be long hauler rashes, what have you.
So would you think that, like, say if somebody is presenting with neuro symptoms, right? Headaches, brain fog, or somebody's experiencing GI symptoms, or, you know, heart symptoms, is that because the spike protein is in that area of the body and it's inflamed and it's bothered, and that's where the symptoms come from?
It's a reasonable hypothesis. So circulation in each person is going to be different, right? Largely, basically, based on chance. And if by chance there is a large distribution of the lipid nanoparticles in the brain and spike protein in the brain, which has been shown now in autopsy studies in Germany and Austria, we know it's there. We know it's in the brain. It's really a very uncomfortable thought to think about the idea that one is going to take a COVID-19 vaccine and some is going to go into your brain.
Right, because what people don't realize that as medical professionals, we are always concerned with things that cross the blood-brain barrier. Is that correct?
It's special. The blood-brain barrier, it's a barrier for a reason. It's a barrier to not let things into the brain. The brain is immunologically privileged, meaning that it is separate and should not have proteins in it that could incite inflammation and start to really, in a sense, start to disturb brain function. Not only that, but we don't want local spike protein in the slow-moving blood vessels, the transverse and central venous sinuses, to cause thrombosis. But it's a great concern that the vaccine has this, in a sense, it's a randomness in terms of the mosaic of cells that take up lipid nanoparticles. We know there's billions of the particles, but we have so many more cells, not all parts of the body can receive it. Now, people have asked me, Dr. McCullough, so many people have taken the vaccine and they're perfectly fine. That there's no problem. You know, why is that the case? Listen, a lot of people take the vaccine. Probably their body manages it. Maybe some stays longer in the deltoid. They get some systemic effect, and the body is a masterful piece of wonderful creation.
Yes.
That the body can, in a sense, digest these lipid nanoparticles, can begin to break down the messenger RNA. In several papers now, myself and Tony Karagopoulos have shown this messenger RNA stays in the human body itself, once the lipid nanoparticles are gone, a long time because of the synthetic analog caps. So there's a 3' end, 5' end. The messenger RNA actually has base pairs that the human body would recognize, but these caps are synthetic. And they're using nucleosides that the human body's never seen before. So the body doesn't have a standard way it can break it down. It must ultimately break it down. But now that we know that messenger RNA is in the body for a long time, it can be transported from cell to cell through little packets of phospholipid called endosomes. We now have a great concern that we're harnessing the cells in a thermodynamically unfavorable way. Each cell is its own perfect balance, right? So it's making its own proteins, it's breaking down proteins, it has its housekeeping functions. Each cell is doing its God-given functions. Yeah. Now we're asking it to say, here's something unnatural. Why don't you really produce a lot of this spike protein? Right. And so one theory is just that in alone and by itself is not going to be compatible with the health of cells and organs throughout the human body. And then once we have enough of this, the great concern is shot 1, we have a load, year and a half to get that out. Shot 2, tack on another year and a half on top of that. Shot 3 at 6 months, another year and a half. We're never going to get out of the body. That there's going to be a loading, clearly a loading of spike protein, that's for sure, and then maybe a successive stacking of messenger RNA or genetic material that the human body simply is not ready to manage.
What I've been seeing a lot lately, I primarily work in women's surgery, so GY and stuff. And I know that they saw that the lipid nanoparticle was accumulating around the ovaries. I'm seeing lots of endometriosis, way more than we normally see, and a lot of adhesion. So now everything is stuck. The bowel is stuck to the uterus, the ovaries are stuck. They're massively inflamed, and they have endometriomas. They have blood, cysts filled with blood. I mean, I'll show you the pictures. It's amazing, and it's far more than I've ever seen in my career. And so I know they're saying, oh, it doesn't happen, it doesn't go by the ovaries, but I'm seeing it.
The Japanese biodistribution study was convincing. The lipid nanoparticles went to the ovaries of animals. Now, the ovaries have a structure in terms of hormonal regulation as well as producing human eggs. It's known in prior papers, one by Ng and colleagues from China, that the lipid nanoparticles in 2018 were known to go to the ovaries and hyperconcentrate in the ovaries. So what we've said is the vaccine manufacturers either knew or they should have known, because it was known that they would hyperconcentrate in the ovaries, but the layer of the ovaries they end up in is the corpus luteum. So this is a hormonal control part of the ovaries, and probably each person is different. Some may get relatively little distribution of nanoparticles and the ovaries are spared. Others may actually get quite a loading in the ovaries. And you're right, we could see all kinds of things, including disturbed menses. We can even begin to see changes in hormone. The reason why corpus luteum is so important is that it's involved in estrogen, progesterone, and even in postmenopausal women, we've seen postmenopausal bleeding because of some estrogen withdrawal that could happen conceivably after COVID-19 vaccination. But what everybody wants to know is, can the vaccines influence fertility? Now, there is a fertility study that was done by Moderna, submitted to the European Medical Association in animals, showing that fertility was reduced in the animals. Now, it's hard to do an animal study and come up with a lot of inferences, but it wasn't favorable. Right? And the issue you're talking about is ovarian cysts, endometriosis, nascent ovarian cancer, uterine cancers. I'm not so sure right now if a vaccine, a 1 or 2 injection vaccine, can, in a sense, enhance these other processes. I can tell you what they can do, though, is they can make symptomatology come forward. So a woman who has endometriosis, who's managing pretty well, little symptoms, now gets seated in the ovaries with the vaccine. Lots of pelvic pain presenting and evaluating. Clearly the vaccines, if there is an endometrial cyst, remember, they actually can promote clotting as well as bleeding, because the spike protein damages blood vessel cells. Now we can have a hemorrhagic endometrial cyst as an example, this type of pathology. There is concern, and along the lines of the ovarian distribution, that maybe shot 1 and shot 2 may not have too much influence in human reproduction. But once we get to regular shots every 3 or 6 months, fertility is a sacred part of the human anatomy. The chances, and this would be my estimate, of these vaccines given on a regular basis to women of childbearing age, so right after puberty, childbearing age, the chances of that influencing fertility over the long term, I think is high.
It's real high.
It's at least in some. It's at least in some. Women. Some women are blessed with having as many children as they desire. Others aren't. Already there is a maternal fertility issue in the United States because women are choosing to have children later. So you can imagine a period of time now where a young woman, let's say, who's age 15, through the COVID years of U.S. history, let's say that woman took 5 years of COVID shots. And then now she's trying to conceive at age 35, and there'll be a question. Did you take the COVID shots there? Is that an explanation for later infertility? It's going to come up.
Well, I mean, they're not really wanting to study this at all, are they?
Come up. No, I'm saying in the future. Don't forget, it's always, when there's a woman who's infertile at age 35, there's always a question about what about at the time of what we call menarche, or the beginning of menses, and the onset of puberty. The other maternal concern, and maternal fetal and gynecologic concern, has to do with pregnancy. And so what we know there is pregnant women were excluded from the vaccine trials, as they always should, because pregnant women are thought to be, again, a sacred group of patients, because it's 2 patients. It's the mother and the child. And because the spike protein is known to be dangerous, causes blood clotting, causes damage to blood vessels, it is the pathogenic part of SARS-CoV-2. The dangerous mechanism of action takes pregnant women out of consideration for vaccination in the registrational trials, and absolutely should take them out of consideration in any type of public program. So in a paper by Shimbowako and colleagues published in the New England Journal of Medicine, there were about 3,000 women who in an ill-advised way came into vaccine centers and took the vaccine and were pregnant. And looking through all the data, the first trimester was the great area of concern. And there was a dispute depending on the denominator that was used to try to calculate the fetal loss rates. And so the fetal loss rates, after all the letters to the editor and the final revision of what the author said, could have ranged from as low as 12% to as high as 83%.
Wow.
For a fetal loss rate from the Shimbowako paper. So myself and Dr. Ray Stricker from the University of California at San Francisco, leaders from Canada, we published an editorial in Trial Site News analyzing the data and basically making the statement clear for America, North America, and the rest of the world that pregnancy is category X for the vaccines, means do not administer, period. That's it. Pregnant women, fortunately, have an easier time with COVID than non-pregnant women.
Right.
So in our hospital, through the pandemic, there is measurement of COVID-19 testing. And pregnant women in our hospital are 5, 10, 15% positivity rate of COVID-19. They deliver their babies fine. So in a paper by Pinellas and colleagues in the Annals of Internal Medicine, analyzed pregnant women with COVID and non-pregnant women with COVID, and it turns out that pregnant women have a reduced risk of all kinds of serious outcomes. So pregnancy is the last reason why we'd want to vaccinate someone. This idea. Pregnancy is not an immunocompromised state. That's another basically false statement I've heard. Pregnancy is an immune-enhanced state because remember, delivery through the birth canal, there's a lot of exposure to bacteria there, and the body actually handles that in an amplified way there. So those are the concerns on pregnancy. Category X, pregnant women under no circumstance should receive the vaccine. And then long term, in women overall, there is a concern now that Banzel and colleagues have shown that after vaccination, both the S1 and the S2 segment are in the human body. The Chinese have shown us in a paper that the S2 segment of the spike protein interacts with 2 cancer genes. One is P53, the other one is BRCA. And women will recognize BRCA as the gene that is related to certain forms of breast cancer, uterine, and ovarian cancer.
That's a BRCA.
That's BRCA, BRCA. Now the P53 gene is also known as the tumor suppressor gene. That gene has strong relationships to renal cancer, melanoma, and other solid organ cancers. So people have asked me, Dr. McCullough, do the vaccines cause cancer? I said, my clinical intuition would be shot 1, shot 2, clear this stuff out, fine. But once we get into boosters given every 6 months and reloading the body with the spike protein and continual exposure of the S2 segment, which doesn't happen in the respiratory infection, but the S2 segment exposed in the human body every 6 months in a sustained way, that clearly could be carcinogenic. So individuals predisposed, you can imagine having renal cell cancer, having melanoma start to pop up, having breast cancer rates start to pick up, and then the female reproductive cancers, uterine cancers. And so because the vaccines didn't undergo any type of testing for carcinogenicity, we don't know.
Wow.
We don't know.
So what would you say, when we look at the lay person who thinks, like, they trust the government, right? They trust them. They say, if they tell us to take a vaccine, we're going to take a vaccine. What has happened to the medical community, in your opinion? Like, does this surprise you that the medical community is I like to call it brainwashed? Because it feels that way, right? From the very beginning with the mask, when we're like, it doesn't work, guys. We know that the virus isn't stopped by a surgical mask, to where we are today.
I wish we had a mask here.
We actually have one, yeah.
We
Oh, I have one. I have one in my pocket.
You do.
Oh, there you go.
I have a mask in my pocket. So I want to put on this mask, and I want the viewers to see this. This would be a typical mask I would wear in a hospital. And I wouldn't do much more than this. I don't think most people do much more than this, right? Mask expert Mr. Stephen Petty, who I presented with at the University of Nebraska, demonstrated with a standard mask like this that 18% of the air goes around the mask. Goes around the mask, okay? It's known that this mask could only filter out 3 microns at best. The virus is 1 micron. But with 18% of the air going around the mask and the 1 micron virus going right through the mask, of course the mask doesn't play any role. Now I am asked over and over again, Dr. McCullough, is masks your signature issue? I said they're not. And the reason is I'm a cardiologist. I'm in the hospital. I wear a mask anyway if I go into the cath lab or control room, or if we go into the operating room for some reason. I think dentists and dental hygienists and other people working at close range, they wear a mask. I think some of it obviously is out of common courtesy. Some of it's maybe to control a big sneeze or something else. And I don't think masks should be an issue. As a doctor, if I say doctors and nurses wear masks, I have no problem. Now, putting masks on people in general, children wearing masks and impairing their ability to learn speech and facial recognition, for masks on people who are well, who are trying to make a critical presentation or a business deal. We know that if 2 people don't have the virus and you put masks on them, that masks can have no role. There are 12 randomized trials of masks, including the Dan mask trial, showing no role of public masking. But your question is, why is the medical community, some of them, not me and not people in my circles, but why are some people, in a sense, in a trance?
Yes.
And particularly in this issue of vaccination, which I think is the most. And we've seen recommendations. The American College of Obstetrics and Gynecology recommends vaccination for pregnant women.
Yeah, and so does the American Academy of Pediatrics.
Right, and despite the clear rationale that I've given your listeners, that pregnant women under no circumstances should be vaccinated, the American College of Obstetrics and Gynecology, with no rationale, and the same thing for pediatrics. No rationale whatsoever.
None.
The children don't get sick. They don't have significant patterns of spread. What's going on? I think what's going on is called mass formation psychosis. This is very important. Now, we're in an anatomical lab right now. The hardest part of this body is what's going on psychiatrically in the brain and going on in the brains of all of us around us. And we know thoughts and our patterns of behavior are contagious. I can actually spread something to you psychiatrically that's contagious. I give credit to Dr. Matthias Desmet at the University of Ghent in Belgium and Dr. Mark McDonald, child psychiatrist in LA. Both have arrived independently at the conclusion that we're in a mass psychosis. Now, we've seen mass psychoses in history before. The horrific group suicides that have happened with religious cults. We knew in Nazi Germany where people, in a sense, offered their children up to eugenics programs in a progressive mass psychosis, and they themselves walked into gas chambers and were gassed to death. They didn't go kicking and screaming. That's a mass psychosis. So what Desmet says is there must be 4 conditions met for a mass psychosis. The first is the population must be isolated. People must be isolated for a prolonged period of time. Number 2, we must have things taken away from us that we previously enjoyed. Number 3, there must be constant free-floating anxiety. Anxiety of more viruses, more disability, more death, more anxiety. Okay? And then the last one is the capper. Number 4 is there must be a single solution offered by an entity in authority. The vaccine. The only solution to the pandemic is the vaccine. We're in a mass psychosis. And what Desmet says is, with the vaccine, there is no limit to the absurdity that we will see. No limit to the absurdity. So this idea of, here, take a vaccine, take any vaccine, that's absurd. The vaccines are different. There must be a winner, there must be a loser, there must be somebody in the middle. Why would there be any vaccine?
It's the same with the mask. Wear a mask. Doesn't matter what kind of mask. Just put it over your face.
The absurdity of, well, I've already had COVID. The CDC says you can't get COVID again. They've actually finally
they finally came out and admitted
that there's no one has ever developed COVID a second time and spread to anybody. They don't have a single case. They have ordered over 41,000 fully vaccinated vaccine failures that led to death or hospitalization. That's just what they have in terms of a sample coming in from the Departments of Public Health. There's probably manyfold that if we have the universe of cases. But they don't have a single case of natural immunity failure. Not a single case. So again, there's no limit to the absurdity. So you've had COVID-19. You can't get it again. Take a vaccine. Matter of fact, if you don't take the vaccine, lose your job. You say, well, I've already had it. Take it anyway. Otherwise, you'll lose your job.
Doesn't matter.
Here's another absurd thing. I'm going to lose my job if I don't take the vaccine. Okay. If you take the vaccine, how much longer of an employment period do you have? I don't know. Oh, that's pretty absurd. So you're being asked to take a vaccine, and you don't even know what you get out of it.
Right. I think I listened to one of your podcasts, and you called it the social contract. You said, well, there is no social contract, right? Because we're just telling you to take it now. Does that mean in 3 months you have to be compelled to take it again, or you're going to lose your job? Or 6 months? Or a year?
How about this one? This one came up today. I had a wonderful person in my office that had a smaller child and said, my child cannot see the grandmother because the grandmother is saying the child must be vaccinated. Okay? Now, the grandmother loves the grandchild. The FDA says don't vaccinate the children because the vaccines cause myocarditis. These are official warnings. So the grandmother is actually, in a sense, pressing or pressuring the child to be injured.
Right.
But yet the grandmother loves the child. And we have 13,000 cases of children being injured with myopericarditis, which we reviewed at the beginning of this session. So in a way, the love relationship is going to perpetuate injury in some, not in all, but injury in some.
But they have, we talked about it before, the risk-benefit. Like everybody does a risk-benefit analysis, regardless of whether they know they're doing it or not, you know? And we have a situation here where we saw the risk for the last year and a half with children, and they are pretty much zero risk from dying. Statistically, zero chance of dying.
And manageable. If I had,
right, they're not sick, they're not hospitalized.
If I had a child in my circle, I'm telling you, as a competent doctor, I could guide the parents through the illness, and I've done it.
Yeah.
And it can be done over the phone, so it's manageable. So, okay, so on the risk side for the respiratory infection, it's not there.
It's not there.
So even a single case of myocarditis would be too many.
Exactly.
You agree with that? A single case.
One case.
Not 13,000.
Nope, just one
case. Is. Do you know that in children with the rotavirus infection, that there were 15 cases of intestinal volvulus. Intestinal volvulus is a loop of intestine that actually begins to twist on itself, and there's a similar problem called intussusception and telescoping. There was 15 cases among large numbers of children vaccinated, and there was a discussion of shut the program down. And the rotavirus program was shut down because the children, a few of them were being harmed. Here, we've already had 13,000 harmed that our CDC is certifying. I reported some cases, and the CDC officer calls me, and we verify the troponins, we verify the EKG, whatever. These are certified cases.
How long, okay, let's get to the VAERS report. So how long does it take you to fill out a VAERS report?
I have to do one tonight from the man who had the heart attack, and it'll probably take me about half an hour to go through it. I have to get all the details of where he was hospitalized, when. I'm going to have to go in the electronic record. I have to go to Care Everywhere, since he was hospitalized at a different hospital, get the cath report. I got to enter it in, all my doctor identifying information, where my office is, my contact information, the patient's contact information. They want the patient's phone number and email. VAERS is extensive. They want lot number 1, lot number 2 of when they received the shot.
Yep.
And every single line it says a falsification is punishable by federal fines or imprisonment. Let me tell you what, I am going to be on my A game when I do this. I may wait till tomorrow when I have a cup of coffee when I'm really awake,
right?
Because I don't want to make a mistake.
Exactly.
I'm telling you, these VAERS reports are pinpoint. They are not casual. In the paper by Meisner and colleagues in the pediatric literature before COVID, we knew that only 14% of VAERS cases are filled out by patients or family members. 86% of the time is filled out by a nurse, a doctor, a healthcare professional, someone who thought the vaccine, in fact, caused it. And we have other assessments of causality in VAERS suggesting they are highly causally related to the vaccine.
And I'll tell you, from being in the emergency room and seeing injuries, people like to say, well, file the report. Well, do the report. That's your job, isn't it? And it's like, there's so many people that, number one, depending on your beliefs, you have to even see if there's a cause-effect relationship, right? And so many providers out there don't even try to do that association and ask. I'll tell you, I've had so many instances where I'm in the room with the physician as he's doing his assessment, and you got somebody that has Bell's palsy or something, and they don't even ask, were you vaccinated?
There's a subconscious program going on in people's minds. And it goes like this. I took the vaccine. I took a risk. I want to suppress my fear of the risk of the vaccine. The next person who comes in with a vaccine injury syndrome, I don't even want to know about it.
Right.
It's a subconscious syndrome that people are going through right now. And vaccine injuries invariably are underreported. Now with death, we actually, in COVID-19, we have a handle on this. Because remember, VAERS is spontaneously reported. So someone, again, you have to have the vaccine card. How many patients die? And there is a commotion, and there is coroners or undertakers or other people involved, and family is scrambling in and trying to make arrangements. Who's going to be digging for a vaccine card and start to put in the details, right? If you even have a vaccine card. A lot of times, personal things are lost. So I had a patient today, and let me tell you, it took a lot of digging before we got to his vaccine card. So we know another database. We know where someone's received the vaccine, and we know when they've died, and that's actually CMS, the Center for Medicare and Medicaid Services, which isn't the entire country, but it's a percent of the country that we know. And so because of that percent, we can extrapolate to a larger number of people who are vaccinated, and then we can actually compare to VAERS, what comes in VAERS, and so we can actually get an idea of what's called the underreporting ratio. And for death with COVID-19, the number is roughly 4 to 5. So if we have 9,000 domestic deaths and it's underreported fivefold, that means there's 45,000. That's exactly the number the U.S. government is being sued over right now of vaccine-induced deaths in the what's called CMS whistleblower lawsuit. It's exactly at 45. Now, as time goes on, those numbers are going to accrue. I mean, we had a real bombshell that came from Pfizer. Remember, the other place where deaths are recorded is actually by the pharmaceutical companies. And so within the lawsuit launched by lead attorney Aaron Siri and co-counsel Elizabeth Brim, they have actually sued Pfizer and the FDA to release the dossier of Pfizer's safety data, since they were first out of the board, they were the first to get boosters, and they were first to get pediatric vaccines. And the lawsuit says, we want to see the Pfizer dossier and have 30 external experts review that. Qualified experts who know how to read safety data, understand this. I'm one of them, so I know. And so, shockingly, the FDA went to the judge and asked for the release to be delayed till 2076. 56 years from now. I'm not going to live 56 years. And they recently extended it even longer in a release, which is absolutely incredible. And so some of the Pfizer files have now been leaked. And in the first several thousand pages that are released, Pfizer already has a couple thousand deaths on their hands in the Pfizer documents.
And now we're talking about just from their trial, the people that took
this is from the public program.
The public program. Now, I also listened to one of your podcasts where you had spoke about monthly, at least, data reports. That this vaccine, there hasn't been any data reports that have come out.
From any government. So,
right.
So the US, UK, Europe, India. In fact, in India, in the Supreme Court of India, the government is being sued because there has been no transparency on the vaccines for safety or efficacy. People in India have no idea if these vaccines work or don't work. and they have no idea. Nothing has been released. Nothing.
Zero.
They're being, and
Zero.
it's just, take this vaccine and you know nothing about it. So in the Supreme Court of India, I've had a chance on the McCullough report to interview Dr. Prashant Bhushan, who's the lead attorney in India suing the Indian government for just transparency. In the United States, we have some transparency. We know from the registrational trials, which now, by the way, with Pfizer is far enough ahead, there's slightly more deaths with Pfizer than those randomized to placebo. So it's certainly not in favor as we get more and more of the continuation data. And then in the public program, we've already reviewed that. We think there's 9,000 domestic deaths with the underreporting factor of 5, 45,000 deaths, and they will continue to accrue. Now, fortunately, the vaccination rates really fell off a cliff in April.
Yes.
You know, from April onwards, the word got out and people were frightened of the vaccines. Fundamentally, people have not taken the vaccines. There's, even in healthcare, there's something out today about healthcare professionals. There has been no movement on healthcare professionals taking the vaccine. And if you ever go into CVS and Walgreens and you go back by the pharmacy, you used to see all kinds of people back there. There's like nobody back there.
Yeah, I think their flu shot will go down, way down too. Because I believe a lot of people, they're just questioning it now.
People have lost trust in the stakeholders because of a lack of transparency. Now, if there was put it this way, if there was a safety report every month, and we had an independent day safety monitoring board, a clinical adjudication committee, and a human ethics board, and we said, listen, we got a problem, the program probably would have been shut down in February because the deaths exceeded the expected number for all the vaccines combined, and there would have been a deep dive. Maybe the doses were too strong. Maybe there were certain types of people who shouldn't get the vaccine. There could have been a correction phase to get the vaccine program on track. I'm not against vaccines. In fact, I was thinking that maybe the nursing home residents, nursing home workers, that's where we had worker-to-patient transmission. By the way, we never had hospital outbreaks. This idea of vaccinating the healthcare workers, it never.
Or what about even, I like to say, dental offices?
Great example.
They are the highest risk.
Right there. And in fact, I interviewed on the McCullough report Paul Gossett, and I've now collaborated with a wonderful dentist here in Dallas, basically showing that they use oral nasal decontamination methods routinely. And so Dr. Gossett told me, for instance, in Chicago, he gets exposed to a red-hot COVID patient. He'll go home and he'll use dilute povidone iodine in the nose and mouth about 4 times a day for 3 days post-exposure prophylaxis. He basically uses a nasal spray. So you have to put enough up in your nose to sniff it back and then spit it out your mouth. And you've actually killed the virus in the nasopharynx. Gargle with it, spit it out. And then that basically reduces the viral load sufficiently that the body can fight off the rest of the viral particles. And even if someone gets COVID-19, doing that markedly reduces the severity. Yeah. Cuts down dramatically the risk of hospitalization and death in a randomized trial shown by Chowdhury and colleagues, 606 individuals randomized at 303 per group. The PCR positivity stayed the same in the COVID control group, but plummeted in those with povidone iodine. Povidone iodine, hydrogen peroxide, even sodium hypochlorite, household bleach, kills the virus on contact. This is the single greatest advance. Today in my office, I went over the remaining susceptible people. I went over what they should do when they go home. Once they've gone out and they've had some exposure, they're not going to get COVID from me because I've already had the illness. And in general, they actually don't get it in office waiting rooms or exam rooms because there's enough airflow. If we get 6 to 8 exchanges of air per hour, we actually reduce the risk of infectivity dramatically. It's in small, closed rooms where there's no airflow. It's there the high risk thing. I think elevators could be at risk. I do worry about public restrooms. There's been one study of public restrooms that did not confirm it, but I'm suspicious because of the heaviness of the air, and we know the virus comes out the respiratory tract, but also the GI tract. So, I'm concerned about that. And so this idea, we know the masks can't protect. So if one comes home, they actually have it in the nose for 3 to 5 days before it invades the body. Why not zap it and knock it down? I have a patient right now who's acutely ill with COVID-19, but I've gone over the povidone iodine program. She has been, in what they did in the Chowdhury protocol, is she's been blasting it in the nose every 4 hours from the onset of the illness. No pulmonary symptoms whatsoever. She's elderly. Today she got her monoclonal antibodies. She's getting the other drugs in sequence combination, about 4 to 6 drugs. And I am telling you, she is a save. She is not going to develop pulmonary symptoms. She's not going to end up in the ICU. And if every patient received that type of high-quality care, it's problem solved. we'll get through the illness.
So what would you like to tell the people about vaccinating their kids, or putting the pressure on the families that either the grandparent can't see them or vice versa? What would you tell them that are dealing with that?
I tell everybody at holiday time, the thing to watch out for is symptoms. The virus can only be spread by symptomatic individuals. So if there's a sick child, we're not going to grandmother's house. If grandma's sick, we're not going over. It's pay attention to symptoms. That's what it's all about. That's what the Swedes did from the very beginning. They never locked down. They pay attention to symptoms. Now, yesterday, I was on Joe Rogan, and we talked about this because we talked about asymptomatic testing. Joe said the problem is that people kind of fudge their symptoms. They feel like they're coming down with something, but they're going to go out to a party and wedding. I said, that's where we need to change. You can't fudge symptoms because everybody starts out with a mild case. I would tell the parents and others, as I've told on national TV since the beginning of the vaccination program, no one under age 30. I mean, that would be a really nice rule. You can't find anything there. But since more and more data have come in, it's just not a favorable proposition for anybody at any age group. Now, fortunately, we've had 200 million Americans have taken the vaccine. It's already done for them. And they have waning immunity. None of the vaccines appear to last more than 6 months. We don't know if there's going to be some trailing effect. I think now is a good time, honestly, for a pause. Let's review the safety on the products. We probably have some newer and better vaccines coming forward, and we can find our way out of the pandemic. I want to finish with 5 points really quickly.
Okay.
I think are really, really important points. The first point overall for the pandemic is that it's only spread from symptomatic person to symptomatic person. We've got 5 people in the room here. Nobody's coughing or sneezing. We can't spread it to anyone. The second point is, if you're asymptomatic and you can't spread it, there's no role for asymptomatic testing. That's got to go.
Yes.
Right? Point number 3, once you've had the infection, the immunity is robust, complete, and durable against all variants. You can't get it again. Now, one can test intermittently positive many times. Once you're done with the illness, we don't need any more tests. Okay? There's someone in my family circles who had COVID-19 early in the pandemic. He's tested positive 17 times. He didn't have COVID 17 times. See, there's this idea of this absurdity, right? There's no limit to the absurdity.
Right.
If we allow absurd statements to be made that you can get COVID-19 over and over again, and you have to take a vaccine over and over again because you get COVID-19 over and over again, you can see the absurdity of that circular thinking. The fourth point, the syndrome is imminently treatable early. It's far less treatable late. We must initiate early treatment. We have wonderful oral nasal decontamination methods we reviewed. For high-risk individuals, we have 3 now monoclonal antibodies. I use them every day in my clinical practice. They work great. And then oral drugs in sequence combination. Probably the most important being steroids and anticoagulants. The 5th point, the vaccines in general, Pfizer, Moderna, J&J, and I'd say AstraZeneca outside the United States, are not sufficiently safe, and they're not sufficiently effective to feature in a response program. And they clearly, under no circumstances, can they be mandated, or can anyone receive any pressure, coercion, or threat of reprisal. If the vaccines even stay in the public program, they can only be purely voluntary.
Is that the coercion, the threatening, all of that, is that against the,
It's against the Nuremberg Code. The Office of Human Research Protections is in play here because the vaccine program is a research program.
Right.
And so they have what's called 6 cornerstones of human bioethics. The first one is the Nuremberg Code. In research, good doctors cannot encourage the vaccination. They don't discourage it either. I have never encouraged the vaccine. I am neutral. All good doctors are neutral. Very, very important. If I had a research study and I was using a diabetes pill and I told a patient, you need to be in my research study. And I'd be, come on, I'm going to force them into my, I'd be called before the IRB. They'd say I have a conflict of interest. The FDA and CDC have a conflict of interest if they are applying pressure on anybody. One cannot apply pressure or coercion or threat of reprisal. The second thing is informed consent. That is Declaration of Helsinki, meaning that if one's going to do this, they must understand the risks and the benefits. So an egregious violation of bioethics recently occurred on Sesame Street. And on Sesame Street, 2 CNN correspondents were on, seducing children to take the vaccine without presenting any fair balance to the parents about the risks and benefits of myocarditis and death in their children.
Yeah.
Yeah. That's immoral, it's unethical, and from a civil perspective, it's illegal. We have laws against that. I'll let that be the last word.
Yes, thank you so much.
Can I